I am going to very quickly turn it over to Eleanor Perfetto of the National Health Council, who's our Strategic Vice President for Strategic Initiatives. And Eleanor?
Thanks, Jason. Now move to the next slide. So welcome, everyone. As Jason said, this is the third in our series, and of course, again, you see the membership of the National Health Council, and today we're going to talk about how patient groups are impacted by alternative payment models and how they can be engaged in the process. We have some great speakers who are return speakers from Part 1 and Part 2. I'm going to begin by just giving a little bit of an overview of what we've already covered, just in case there's anybody on the line who wasn't able to join us for the first couple of sessions, and then we'll move into the discussion with our guest speakers. As I said, short review, and then the guest speakers. So in Part 1, we covered an overview of alternative payment models, and we talked about how in our background that we were looking at that healthcare environment concerns, predominantly over cost, but also over quality. And in the past, we had incentivized volume over value through misaligned payment incentives. And basically what we mean by that is we were working through a fee-for-service payment model, and in that kind of model, you're paying people at each time they do something. So you're incentivizing them to do more. You're incentivizing value, rather than incentivizing doing a good job. And so alternative payment models are really geared toward trying to incentivize value. So today we are working to incentivize value through these alternative payment models. Again, just a joke on how we had a reliance on the fee-for-service model. So, paying for all of those things that got picked off of a menu rather than making sure that they were the right things to be providing to that individual patient. In Part 2, we talked about an introduction to payment models. We introduced some basic terminology. We talked about the types of alternative payment models, and we discussed in more in-depth value-based payment or incentivizing value. So as a refresher, what's an alternative payment model? A payment approach that gives incentive payments for providing high-quality and cost-efficient care. And we talked about the various types of alternative payment models. Some of them are coming out as bundled payments, where providers are paid for a bundle of services that they provide, but it's usually a capitated amount of money or a capitated amount for an episode of care, and that episode is usually defined by certain things happening before and after a certain episode happens. So it might be the care for a heart attack. It could be the care for that individual to be taken in an ambulance to the hospital, care in the hospital, and then post-heart attack care. Capitated payments and population-based payments, meaning paying those providers an amount of money, a pre-specified amount of money to take care of an individual patient or a population of patients. And then we saw with the Affordable Care Act, accountable care organizations come about and shared savings programs where organizations could band together to provide care for a population, and in doing so, they would look to have better care coordination, be able to care for that population of patients at a less expensive amount of money than they had the previous year, and if they did realize some savings through what they had done, they would get to share in those savings. So the Medicare Shared Savings Program being a prime example of that. We've evolved from looking at measurements and quality and other kinds of reports. We've evolved from publicly reporting those things, so where the providers would provide a report on those measures and the measures might be made public. And the thing that those providers got back was public recognition that they had been part of the reporting process and public recognition if they had good reporting. They were not being paid for their performance. They were simply being incentivized to report. And then we had pay for reporting. Doing the same thing, their performance was not assessed, but they were being paid for that reporting. And then now we're moving toward pay for performance, and that is receiving a bonus or a penalty in some cases, money being taken away because you didn't perform well or you didn't report. So this is the evolution of using these measures. They're being reported, they're being required in some cases, an evolution of them just being collected and reported publicly to now being required, and payment is dependent on them. We talked a little bit about the CMS Quality Payment Program. This is what was known as ASGR. It's now MACRA, and under MACRA there are two different payment systems, the merit-based incentive payment system and the advanced alternative payment model. And we introduced that discussion as part of our discussion on MACRA and the future where CMS is going with alternative payment models. And then lastly, on our last call several weeks ago, we talked about how all of this work by the government in alternative payment models, especially the Medicare program, spills over into the private sector. And we see that private payers now also have incentive initiatives. They use this in their marketing, and they are geared toward cost containment. And we heard a speaker from Aetna who talked to us about the work that Aetna is doing in this area. So what we want to do now is have a discussion. How does this impact me as a patient? How does this impact a population of patients? How are patient groups impacted by this? And how can patient groups engage? And so we have some guest speakers here today with us who have participated in this series. We're happy to have them back so that they can talk a little bit more detail about what their organizations are doing. I want to begin with Tanya Safer, who's from the National Kidney Foundation. Then we will turn to Elizabeth Franklin from the Cancer Support Community, and then we'll close with Adam Thompson, who's with Kennedy Health Alliance Infectious Diseases.
And Tanya, you are off mute.
Okay, great. And you're advancing my slides, right?
Yep.
Okay, great. Thanks, and thank you again, Eleanor and Jason, for having me back on the webinar. I think, I'm very engaged and interested in this topic, so very happy to talk to this group and see this as a priority for the National Health Council to engage patients and patient advocacy organizations in alternative payment models. I know we'll have a Q&A session. I had some questions on my very first slide, my second slide actually, around current models that exist. And it's really, I think we know some of the answers to these questions, but I think it's really for the group to weigh in on, and we can certainly dive into this after I go through the rest of my slides. But I thought I would kick it off with some of the questions that I think are obvious. But the first is, do patients even know when they are in an alternative payment model? And I think broadly, my answer to this, or my perspective from just, the ESRD patients, the patients that have kidney failure and on dialysis, who may be in some of these new ESCO models that I talked about previously that CMMI runs, some of them know, some of them sort of know, but I think by and large, they don't really know. I think for now, patients are receiving care at for the most part, the same place they were receiving care before. I think that that's true for most of the models. And they may have received some notification, some piece of paper that describes a little bit about how care is delivered and the data sharing that's going on with their healthcare provider and their health insurance company. But by and large, I don't think that the average patient really understands what an alternative payment model is, or how, even if they are in one. I don't think we have a good understanding if patients are more satisfied in care, at least not in the ESCO program. We don't really know the answer to that. I know Elizabeth, and I missed the last webinar due to the flu, so I apologize. I know Elizabeth presented a little bit about some of the work that they're doing, and she'll probably elaborate on that too, to really try to get at this question. Are patients more satisfied with care? Do they believe they're receiving higher quality care in these models? I think that's still an outstanding question. Are patients getting the treatment that's in alignment with their personal goals, preference, and value? I think there's a lot of work still to be done in that area as well. And then, do we know if outcomes are improving? I think we've seen mixed results of different models as to whether outcomes are improving or not. Certainly, I think from the models that have results, they're not getting any worse. But are we seeing true improvement in outcomes? I think that still remains a question. So next slide, opportunities for individualized care. I do think that there are opportunities here for patient advocacy organizations to shape the conversation, to shape models and particularly for members of the National Health Council, who often, the patient advocacy organizations represent patients that have very specific needs, very specific chronic conditions, and very specific disabilities. And CMMI has called and indicated support for broadening, broadening out opportunities for additional alternative payment models, and specifically for specialty models. So I think that there is really an opportunity for patient advocacy organizations to engage in the development of those specialty models, to really move those models in a direction that they are measuring what matters to patients, that they are delivering the services that would help patients receive the care that they think is best for them and for their condition. So I think that there's a great opportunity here when it comes to specialty models and CMMI's interest in them. There are very few specialty models that exist currently, as I think we mentioned before. Most of the models are focused on primary care. There is an episode-based cardiology model. There is, of course, the oncology care model. And then there are the SK models in the nephrology community for kidney patients. Next slide. I think also signals from CMMI that we have heard that provide an opportunity for patient engagement that came from the IRFI, but also comments that CMMI leadership has made in various forums, including at the National Health Council annual meeting back in December, is that CMMI is looking to change directions. And one of the directions that they're looking at is, looking towards new alternative payment models and displaying information about those models to help consumers make informed choices about where to receive care. So I think, and would suggest that as CMMI is determining how to be more transparent with these models and what information it wants to have these models communicate and publicly display to help consumers make informed choices, that before that actually happens, we really need the patient advocacy community and patients to engage in discussions about what these public measures or public information is going to be made available that's going to help patients decide where to receive care. Because if this is just determined by the physicians or the clinicians in the model and by CMS staff as to what information is necessary to communicate to the public so that they can make informed decisions, I think it's going to be lacking. And to go back to my example in the first webinar that we had, and where I presented the example of the dialysis facility compare rating system and the star ratings, I think CMS had learned that what the measures that they were putting out there and what they were basing their star ratings on wasn't necessarily the information that patients were seeking to try to help them make decisions about their clinics. And so CMS has gone back and been engaging patients more on that particular point. But I think throughout CMS, there needs to be more of that, engagement of the patient up front, understanding what they base their decisions about where to receive healthcare on and what would be important for them to see. So I think that's an opportunity as well.
Hey, Tanya?
Yeah.
Really quickly, sorry, we just had a quick question. I think you can get to it quickly, but what is CMMI? Just to break that out, get away from the DC acronyms.
CMMI is the Centers for Medicare and Medicaid Innovation. They are the entity at CMS that was created by the Affordable Care Act to develop and facilitate new alternative payment models. So any alternative payment model that's created, even if it's created by an external stakeholder, would have to go through CMMI approval and vetting and a lot of other steps to be able to be run through the Medicare or Medicaid program.
Thank you.
Sure. Sorry, I apologize. I thought that was an acronym that we had shared before, but okay. My next point is really about empowering patients to make decisions about their care, their treatment at the point of care. And I think these models provide an opportunity for greater patient engagement. I think I said this on the last webinar I was on. But we need the right tools and the right resources for patients to really be able to participate in shared decision making. I'm not sure that the current models that exist do a great job of that. Some participants may do a better job than others. But most of these models don't really require a focus on shared decision making. And so I think that that's another opportunity for engagement of patient advocacy organizations, as well as new models are being considered and new criteria for models are being considered. And I've crossed out here that's intentional. My next bullet is adherence to prescribed care, and this really gets back to my point on individualized care. Oftentimes we hear, and we still hear this from folks at CMS and from healthcare providers is, well, there's only so much that a physician or a practitioner can do to improve outcomes for a patient if the patient doesn't adhere to their prescribed treatment regimen. And this is a conversation I know that our organization has had with CMS staff, with NIH staff, CDC staff. Just, we really need to change this conversation around, away from adherence and, flip the script. If we want models to provide support for more individualized patient care, for care that helps patients achieve their goals and ultimately achieve better outcomes, we really need to tailor the messaging to, that very first point, that very first encounter with patients as to what their personal goals are, not just their healthcare goals, but really what are their personal goals, aspirations, and then, as a healthcare practitioner, change the conversation to how the treatment can help them meet their goals. We also really need to understand patients as people. What are the barriers they face in their everyday lives that might help, hinder their ability to, go a certain course of treatment, to take a certain course of treatment. We, think that those are the conversations that need to happen, and that I think alternative payment models could promote if we had the right criteria and the right measure in them for those conversations. And I think we would see a lot of improvement in clinical outcomes as well as cost effectiveness of these models. And again, just what does success and high quality care look like, and how is it measured? I think that's really an area where patient advocacy and patient engagement is just lacking and necessary. And I know the National Health Council has done a lot to try to engage patients in quality conversations. And so I think there's an ongoing role and an ongoing need for those conversations to continue, but also continue in a forum, like with CMMI, that is looking for new measures and can test new measures through new models of care in a way that they don't have to prescribe to the current CMS MIPS program of a measure going through that process before it can be implemented. They have flexibility at CMMI to test and look at new measures, and so that that's another opportunity to really advance measures that are more patient-centered. I just wanted to give an example of what our organization is doing, and then I will quickly wrap up. The National Kidney Foundation recognized that there was a significant gap in kidney care, mostly, at the point where patients are under primary care. They might have diabetes, they may have hypertension. What we often hear from our patients that end up with kidney failure is, why didn't somebody tell me I had kidney disease before my kidneys failed? This is a question that I think we've struggled with for decades, and ultimately, more recently, we've now seen the opportunity with alternative payment models to do a better job at providing overall care for these patients. And rather than get stuck in this where they're, a patient is going to their primary care provider because they need, their diabetes managed, or, they might have signs and symptoms of hypertension, or they just need their flu shot. These, fee-for-service encounters, the alternative payment model really provides an opportunity for a clinician to sit down with a patient and say, okay, what is the whole, the whole picture, what all is going on with you, and provide longitudinal care for that patient. And that's really important for chronic kidney disease in that this is a disease that progresses over time. So we decided, and I'm not suggesting that every patient advocacy organization go down this path, but we decided to develop our own recommendation for what a model of care for chronic kidney disease should look like. And this is chronic kidney disease, not those that with kidney failure, but basically a model that would improve earlier detection and adjust slow the progression of chronic kidney disease and help with the transition to treatment options if the patient does experience kidney failure. We did this by convening a multi-stakeholder disciplinary group, so it wasn't just patients, but we did certainly have patients involved in the stakeholder group. We had physicians, both primary care practitioners and nephrology practitioners. We had a social worker, we had a dietitian. We basically had the entire community of providers and people involved in caring for kidney patients in a work group that met for a period of a year and a half to develop recommendations for a model. Like I said, I don't necessarily suggest that every patient advocacy organization needs to develop a model, but certainly would suggest that there are opportunities for patient advocacy organizations to partner with provider organizations that are in payer organizations that are working to develop these models, because it really does change the conversation and the focus of the model. It went from, providers saying, well, we need this to be easy to meet and less burdensome and, really allow for a great deal of flexibility, to a conversation where practitioners were advocating for very specific criteria that met the needs that the patients on the stakeholder work group were raising. Things like, well, I need to be able to access a pharmacy or talk to a pharmacist when I have medication questions. I really want to be able to access a practitioner 24 hours a day, 7 days a week, because I work and I just can't do the 9-to-5 conversations. I've really experienced poor transitions in care. My primary care practitioner never talked to my nephrologist, or I got 2 different conflicting messages from those providers. So it really did change, I think, the outcome of the model by having the patients involved in the conversation, and really got the clinicians on board for doing something more robust and more holistic in model design. So my last slide kind of details out where I think patient advocacy needs to be proactive, but I think I've hit these points, so I'll go ahead and stop there because I think I've gone over my time and I apologize.
No, thank you, Tanya. Appreciate that. And hang on the line so we can get to the questions and answers with you, Elizabeth and Adam. And Elizabeth, I am going to take you off mute, and so you are good now.
Great.
And I will move the slide.
Great. Thank you to the National Health Council and to my friend Tanya. That was an excellent overview of what you guys are doing and kind of tease my presentation up very well. So I'm excited to join you again. As mentioned, I'm Elizabeth Franklin with the Cancer Support Community. On the second webinar, I went over what the cancer support community is doing in terms of a study on the oncology care model. I'm happy to answer questions about that or encourage folks to go back and listen to that if they missed it. But I wanted to take a step back with this webinar and really give you the foundation of how we became involved with the oncology care model. And I think that these steps can be put forth by any sort of patient advocacy organization or anybody interested in becoming an advocate involved with APMs in general. And so I really wanted to start from the basics. You see the slide here, but starting with why. I really think it's incredibly important to understand why you're interested in becoming an advocate within APMs and for us with the OCM and determining what you have to offer. And so I'm going to kind of walk through this, but I think asking yourself both what's in it for me as an organization or as a patient, and then also what's in it for CMMI and what's in it for all of the stakeholders, because it's incredibly important to be involved in the creation and implementation and evaluation of APMs. So I'm really going to start from scratch and walk through what that process can look like. So Jason, if you'll go to the next slide. So thinking about what the mission of your organization is, I think Tanya did a really nice job of laying out why her organization is interested in creating their own APM and moving forward with that. And so I'm just going to use the cancer support community as an example. We are a cancer patient organization that is dedicated to empowering patients with knowledge, strengthening them with action, and sustaining them with community. But what really makes us different from other oncology organizations is we're really focused on the full patient experience. We don't just advocate for access to physical or medical care, but we're really focused on the social and emotional side of things as well. And so when we are thinking about APMs and when we are thinking about the OCM, who is our audience? Our audience is patients who depend on us to advocate for the entire sort of comprehensive scope of care. And it's really important also to remember, I've talked with a lot of groups who are provider groups, and at the end of the day, APMs were created not just to change the way that providers provide services, but to change the way that patients receive services. And so if you're a patient advocacy organization and you're not necessarily involved with providers, or even if you are, it's really important to understand, and Tanya touched on this too, how are patients experiencing APMs and what are they getting out of this? And so it is also incredibly important to note that even if you don't get involved and even if your organization does not get involved, APMs are not going away, right? We are within the realm of moving, as Eleanor said, from volume to value, and so whatever value looks like is currently being shaped by a variety of stakeholders, whether that's payers, whether that's industry, whether that's the government, and patients have to be at the table. Patient advocacy groups have to be at the table to mold what these are going to look like. So I really encourage everyone on the call to think about what is my organization's mission and what would be a reason for me to become involved in advocating for some part of APMs. So the next slide, asking yourself what is it that you want to accomplish. Tanya mentioned that they are introducing their own APM, which is amazing. She also said that may not be within the scope or capability of your organization, but that sort of is the biggest thing that can happen, but you can comment on various APMs. For us, that included thinking about when the OCM was being created, the oncology care model, which is a specific type of APM, what did that look like? If we were measuring quality, what did that mean to patients, and how are we going to be measuring that quality? Do you think that there needs to be something evaluated that's not currently being evaluated, and what could that look like? Can you provide opportunities for grassroots advocates? As I was doing a little bit of research for this presentation, all of the provider groups do an amazing job of outlining what APMs are, what the OCM is, what MIPS is, all of these different things, because providers really need to understand it from a business perspective because it's changing the way that they practice. But to Tanya's point, do most patients understand what an APM is? When a patient enrolls in the oncology care model, they receive a letter. Do they understand what that actually means? Is it meaningful to them in their daily life? And so, providing opportunities for patients and grassroots advocates on the ground to really understand what it is and bringing that information to them in an understandable way, that's an incredible way to advocate and to bring this to your community. I also think that collecting stories, I put the pictures up here. These are our actual patients receiving care in cancer support community affiliates across the country. Collecting their stories. Are you a part of an APM? What does that look like? I referenced our study that we're doing on patient experience in the oncology care model, and we're collecting that information through focus groups and through a survey and saying, are you receiving these specific enhanced services that are a part of the OCM? And if so, what does that mean to you? Is it helpful to have a 24/7 call line when you have questions? If you ended up in the emergency room, did your practice follow up with you to find out what happens? Collecting those stories, I don't think that any organization can collect enough patient stories because that's really incredibly important when you're going to CMMI, when you're going to members of Congress, when you're going to others and saying, look, this is what's actually important to the patients because we collected it from the patients. And then finally, just staying aware of policy implications. I think that webinars like this, opportunities to gain information, incredibly important, because staying aware of the ins and outs of the various APMs that will impact your patients and your community, incredibly important. So I commend everyone for joining this trilogy of webinars, which have been incredibly informative. So next slide, please. And what is your evidence? You know, we're incredibly fortunate at the Cancer Support Community to have a research and training institute. We have doctorally trained researchers conducting research. We have a cancer experience registry. We're putting out data constantly about what cancer patients care about. If your organization is not to the point of being able to do that yet, it doesn't mean you can't gather evidence, right? It doesn't mean you can't gather stories. It doesn't mean that you can't be talking to your patients. I would be shocked if anyone on the phone is not constantly in contact with patients, talking to them about the ways that they interact with the healthcare system, the different things they value. You know, if a patient is undergoing a treatment that they love, but they can't afford to park at the facility, then, you know, maybe that's something that should really be talked about. Or, you know, just really getting at the heart of what it is they value. Do they value not having to go in for treatment several times a week? They would rather do it twice a month, things like that. And really get at the heart at what they care about, and we can only do that by going straight to the patient and asking them what they care about. And next slide. So our target, obviously, when talking about APMs is CMMI, which Tanya referenced. You know, just like Advocacy 101, relationship building, we have been partnering with CMMI since they emerged. You know, for us, working with the OCM team, introducing your organization, saying, here we are, this is what we do, these are our patients, this is our reach, helping them to understand. I have always had incredibly positive interactions with the folks at CMMI. I know everyone on the CSC team has. They're very open. They want to understand what patients care about. And so I encourage you to figure out who it is that you should be interacting with based on disease state or based on project. Develop those relationships. You don't want to just come out of nowhere and say, you know, we're mad about X or we like Y. You really want them to know who you are. And then back to that, what's in it for them? You know, why should they care? What is it that you offer, and what is unique about your organization? So I encourage everybody to kind of think about that. You know, why would they want to work with you? Why would they want to work with your organization? And the answer is because you represent thousands, millions of patients across the country, and they really, really need access to that information. And so putting it into that kind of digestible format and stepping forward and saying, you know, we're the Cancer Support Community. We have a cancer experience registry of tens of thousands of patients. We really look at the full patient experience, and this is information that is indispensable as you formulate these models, is incredibly important. So I encourage you to come up with that, you know, quote, elevator speech and pitching it in a way that would be important to CMMI. And then the next slide, you know, I also think it's incredibly important to partner with other organizations. For our OCM study, where we're analyzing the cancer patient experience within the model, we're partnering with other patient advocacy organizations, actual patients and caregivers, other provider organizations. You know, as a patient group, we have found it incredibly important to partner with groups, provider groups, oncology groups that can say, you know, we can help you to recruit sites that would be interested in this. We can give you more of the provider side of things, and really look at it in a different way, because it's incredibly important to capture all sides. For us, individual practices, especially those engaged, for us, OCM practices, talking to them, seeing what they like about the model, what they don't like about the model. And then I also think it's incredibly important to not just be talking with the physician, even though they are obviously indispensable, but talk to the nurses, the social workers, researchers, patient navigators, policy professionals. So many people have a stake in these APMs, and they have, you know, they could have very different viewpoints. So it's incredibly important to understand, what they all bring to the table, how they view it in addition to the patients, and address it from that interdisciplinary position. So that's really how we have approached this. Again, we are currently running a study engaging patients and finding out what their experience is like in the OCM. But those are kind of the basic points that I wanted to make. I know my information's on the next slide. I'm happy to chat with anybody who has questions, and I just appreciate being asked to present on this final webinar. So thank you, Jason. I will turn it back over to you.
Thank you, Elizabeth. Really appreciate it. And again, hang on for the Q&As after. Next presenter is Adam, and Adam, I've just unmuted you. Adam Thompson here, and I know he's got a few things to say sort of on the individual patient perspective and some of the things he's worked on in his career.
Sure. Thanks, Jason. I think what I should start with is sort of why we focus so much on the individual patient level in HIV care. That's the sort of disease state I work in. I'm both a patient and a person that works in the system. And a couple years ago, our national patient sort of advocacy organization pretty much exploded. And we no longer had sort of a national or even regional voice for persons living with HIV. So it really challenged us to have to think about what we did in that void. We also are funded primarily through the Ryan White program, which is a federal program, which allows us to sort of dictate what our environments do a little bit more than other sites that are not primarily grant funded that way. So I just thought that was important background information. In HIV, what we've done around the issue of value was really try to help our patient community answer the question, what is valuable? And that was something that we thought was going to be easy, that we would just ask people and we would get answers, and it was not easy at all. And what we sort of discovered in the process was that this question of quality care, that our patients didn't really understand it, and that when we asked about high quality care or valuable care, a lot of our people said back, well, I'm not dead. And with AIDS being that fearful endpoint of the chronic disease, a lot of people found value in just living. So it really, again, created sort of a conundrum for us because we didn't want to disrupt anyone's value in life itself, but at the same time, we wanted to be able to further this conversation and really inform those policymakers around what HIV-positive individuals found valuable in their care. So what we went about doing in the absence of our national effort was we identified our individual clinics where our persons were being treated, and people with HIV, it's now a chronic, highly stigmatized disease with expectations of primary care. So it's kind of like we sit both in specialty and primary, so it's a little bit of an odd spot. But what we did was mandated through our system that these quality management committees and quality improvement teams have to have a person living with HIV sitting on them. And in order to sort of operationalize that, we had to develop training for persons living with HIV to understand things like advanced or alternative payment models, as well as understanding performance measures, even the very basics of what we were talking about, so that when individuals sort of then got this experience sitting at a quality improvement table or a quality management team, they could then sort of like take that next step and sort of become a little bit deeper involved at maybe a regional or a state level. And then what we've seen over the last 5 years is the growth of our community over time, where now we have a cohort of individuals who I would say are very steeped in not only in measurement, but in understanding how their care is paid for, who are now able to make some pretty savvy comments from the patient level as their experience in their care. But we had that challenge of building from the patient level up in order to define that question of value. Another effort that we undertook that I thought was really helpful in us getting at what our community believed around value, and this was rolled out in New York State, was a project called the Health Stories Project. There was a qualitative study that looked at the use of blurb cards, which were basically just small cards people put comments on, and then they word clouded those comments at each touch point inside the clinic to get a sense for what was happening at each station so that we could begin understanding what the total patient experience was in that environment, so that when environments say, you know, what could we do to be better for our patients, we were able to go step by step and answer that question. But what I think is interesting is that in opposition necessarily to a national thing, our approach was at the clinic level. And I think we would much like to have a national involvement and do the sort of more consensus building that the patient advocacy groups are doing. But I think at the same time, there's some relevance in recognizing that these advocacy organizations that you all belong in not only have these great patient networks, but they have the ability to infiltrate the clinics, because these clinics feed the providers and the physicians and the thought leaders who go on to these other tables who answer the question of what is valuable. And so I think the more individuals we have across the country and in different environments with an understanding of quality and value and payment, the more likely they are to not only influence their own environment, but to then influence those who may have voices outside that environment at these measurement tables, at the payment tables, at our governmental advisory boards where these decisions are made. So I think it's really, my advice would be, how do we fit both of these two worlds together so that we make sure that we're reaching up to the thought leaders making decisions, as well as reaching down and out to all of our folks across the country living with the diseases that we represent. It's a big challenge, but I think if we're going to have a meaningful conversation about what is valuable, I think it's really important that any patient we bring to the table has the same background to understand the context of that question. Because in HIV, we're very quick to tell folks that our seat at the table without capacity behind it is tokenism, and we never wanted that. So by adding that extra capacity there at the patient level, it allows grassroots movement, but it also creates a cadre of folks that understand value.
Thanks, Adam. Appreciate it. So now we are, if you're finished, Adam, I believe you were. I'll take that as
yes, sir.
So any questions for Eleanor or our guest speakers? I know we have a couple that we can probe, but if anyone wants to type those into the chat feature, that would be great, and we can get it started with our first question. Eleanor, you want to take this one?
Well, sure. I think some of our guest speakers, have already started to address some of these things. So if any of them want to jump in, I think the question from the National Health Council perspective that we'd like to hear from any of the patient groups on the phone is your community or are your members informed about APMs? What do they know? What do they need to know? What do you have going on in your organizations? We'd like to hear what's going on out there. And anybody's free to jump in, including our speakers who touched upon some of this.
I'm going to unmute everyone, so if anyone has any thoughts.
Yeah. Hi, Eleanor. This is Elizabeth with CSC. I'll jump in. Part of the feedback we originally gave to CMMI when they released the OCM beneficiary letter that patients were going to be enrolled, we really provided some feedback to them in the beginning about what we thought worked and what didn't work. And we found that relationship has really grown, and they've come back to us for more feedback, not only about the letter, but also about the patient-facing website, about, what kind of language is it that would engage patients, the reading level. So I think in general, patient, at least in the OCM, understanding is growing, but that's one thing that we're really trying to get to the bottom of with our study. We're going to ask patients, do you know you're in an OCM practice? Do you know about the enhanced services, and are you receiving the enhanced services? So I think that there's a lot of room to grow, but CMMI has been a great partner in reaching out to us and other oncology organizations to say what works and what doesn't, and how can we partner together.
Other groups, just to get a sense of what groups think about their constituents and their level of knowledge or their need for more knowledge on this topic.
So this is Tanya, and I would say that there's still, even within our constituency, where some of our patients are in alternative payment models, and we have talked a great deal about this, I think there's still, even more broadly, a need for a basic understanding of what an alternative payment model is and how it's different from the care that they may receive now and how it isn't different. So I think there's still a need there, absolutely.
What kind of concerns are people hearing about? I know, Tanya, I believe it was you that raised the concern of do people even know if they're in an alternative payment model? So they may be concerned once they find that out, but if they don't even know, they're probably not even able to express a concern about that. What kinds of concerns are coming out around that type of issue or other kinds of concerns? Anyone have any comments to make on that? We'd like to hear more about what's going on out there in this area.
This is Adam. I'll bring up one that's been a kind of a thorn in the side of our community. As folks sort of adjusted to these more value-based outcomes, kind of turning their system, people living with HIV were very attuned to having a CD4 count done every 3 months. And that CD4 count was our measure of our immune strength, and it was a proxy for patients to know how healthy they were, that if the number was high, they were good, and if it was low, things were going bad. When the value-based sort of frameworks came in, one of the things they had identified was that the CD4 count was no longer clinically relevant for individuals that were virally suppressed. And so they took the recommendation that that measure be used for patients. So suddenly patients across the country, especially those who've been living with HIV for a long time, were no longer receiving this number that they had attached so much value to because it was their understanding of their health. And so a lot of effort had to be put in to re-educate patients about how actually that number wasn't actually that good and that there were other indicators that were better numbers. But I think we were a little bit shocked by how attached people were to a value of a lab value that was becoming meaningless to the clinician but was very meaningful to the patient. So it was kind of a change for us where we took something away and didn't think people would miss it, and they really did.
And people may have known that in advance if there had been maybe a little bit more communication and interaction earlier before it was implemented.
Yeah, absolutely. The physicians were educated, but I think there was never messaging to our community about it, or even, I think, the bigger discussion, how valuable that number was to us to even have a conversation about whether it was good to take it away.
Right. Good point. Very good point. Great. So let's move on to another set of questions we have. Is anyone out there, aside from some of the discussions that we've heard from our guest speakers already or anything that they might want to elaborate on, is anyone out there planning on providing education to their memberships, their constituents on this? And if yes, can you tell us about that? Is it sometime soon? Is it something you've already done? We'd like to hear about other educational programs that are going on in this area that we might learn from. And guest speakers, anything formal that you're doing with training?
Through the AIDS Education and Training Centers, we have trainings that we do for patients on quality management, and more we've noticed as the communities mature, they get more and more interested in understanding the nuances of the value-based payment. So we've added more stuff into our programs about it, but at this point it's still very, very basic, where we're educating on the conceptual shifts that are taking place. So this volume to value, but without getting too into the weeds about it until we see that there's sort of a community movement in their understanding of these shifts, and then our intention is to go in and explain more, because we hope to be putting folks on to committees that will define what the other groups were talking about, which is what does value-based HIV care look like, because we don't really feel like we have that answer yet, but we think it's a long game for us, so that the training is, we're thinking multi-years to get there at the community level.
And this is Elizabeth. We have provided policy information to our grassroots advocacy listserv. We are currently, engaging in this research project to find out what patients really care about, and then we will use that evidence to create more education materials and learn from the patients to decide, what they need from us and how we can provide the best information.
Excellent. Any other thoughts there? All right. So I think we say this question with a little bit of sarcasm, but is this topic too complicated for patients? And then looking elsewhere, and I think we've heard this as well, that providers are fairly well educated, but perhaps not on the patient side of it, but should APM education be targeted at other stakeholders such as providers?
I think what we're thinking about here is not so much is it too complicated for patients, because we know that patients need to know this information, but is it really something that we might not want to send out a blanketed information to individual patients without ensuring that they have some place to go to ask questions and things like that. So I think this is a question that's the difference between, from the National Health Council's perspective, educating patient advocacy groups so that they can support their constituencies, as opposed to educating the general public, educating patients in general, or public service announcement kinds of things. So just your views on that.
So this is Tanya again, and I would provide the view that the very similar process you all use for educating patient advocacy groups on quality measures might be a similar model that you could use for educating on APMs. I would work, in a more of a train-the-trainer approach with the patient advocacy organizations, because, I think these models will be tailored if there are more specialty models too, and the existence of current specialty models will allow those advocacy groups to then tailor their messages accordingly and their education accordingly.
How about the education? Thank you for that, Tanya. How about the education of other stakeholders? My thinking is not just educating them about APMs, because certainly if your paycheck is dependent on an APM, you're learning all about it. But what about the role of education in getting providers and other stakeholders out there to think about having patients involved in the conversation and involved in the APM discussion, especially in advance of implementation? So, for example, the example that Adam gave, where something got rolled out that patients didn't expect, and they were thrown by the reaction that happened. How about that role of how do we get providers and other stakeholders to think about the role of patients in all of this?
So we've had a lot of luck partnering with the Association of Community Cancer Centers and the Community Oncology Association. They've been incredibly helpful to us in terms of finding OCM practices, and I think we're learning from them in terms of what providers need, and they're learning from us in terms of what patients need. And so I think engaging as patient advocacy organizations, engaging with provider groups and vice versa, to have lessons learned, to say how, what is it that we need to do for you and vice versa, that's been an incredibly useful way to engage in these things with us, because we wouldn't have the kind of information that we have unless we were working with groups across the aisle and vice versa. So I highly encourage groups to partner with their provider groups and make sure that you're informing one another and partnering together.
I think that sounds like a great model, Liz.
I would also recommend really looking to target and educate those folks who are already closely aligned with patients. Here in New Jersey, we have community health workers that work in our HIV clinics, and anytime I need something that to go out to the patients and to make sure they understand it, we build the capacity of our health workers, who are individuals who have a shared lived experience with our patients. The other group of people are our patient advocates, like inside the hospitals, so that they can begin to understand and see this lens of value, and then see when a patient comes in when maybe that didn't happen. The other group of people that I find to be really fierce advocates on the care team are also social workers. And they're often left out of these conversations because sometimes they're billable, and in some environments they're not. But I think it's important to have them in there because they carry the story of the patient, and a lot of times that value can be culled out of those narratives that they hold.
Great, thank you. In terms of transparency, what do you think patients expect to be told? I mean, in terms of the APMs that they're in, of course we expect them to be told that they're in an APM. What other kinds of information do they need? What are the other things that they expect to hear from the insurers, the providers, the administrators of these programs about the programs that they're in, not just simply the fact that they're in one?
Well, for the oncology care model, I think it's really important, not just that you're in a practice that is a part of an OCM, but what does that really mean? Encouraging them to understand, instead of just saying you will have access to patient navigation services or you will receive a care plan, what does that mean? So we will have a 24/7 phone line that you can call in with any question that you have. If you're concerned about going to the emergency room, we can figure out together if that's the best move. Having access to, as Adam said, a social worker or a patient navigator, or what it really means for them on the ground, and messaging that in a way that patients really care about, because it's, they may not care as much. They might care about having access, their doctor will have access to their electronic health record at all times, but they might care more about being able to talk to someone about social and emotional distress. And so I think having a very honest conversation with them about what those enhanced services look like. And then also, I think engaging in that cost conversation and the finance conversation, saying, for patients who want that information, would you like to understand more about what this means from a societal sort of cost? And I know that time is limited and physicians can't do it all, but I really second Adam, and I am biased because I'm a social worker, but I think looking to other members of the care team, whether that's a nurse, a navigator, a social worker, whoever it is, just to sit down and have a conversation and say, I want to tell you a little bit more about what this is and why we're engaged in it, because we really want the best care for our patients, and we want to do it in a cost-effective way. I'm going to provide this information to you, and then I want to give you time to ask questions. Some patients will not care. That's totally fine. Some patients will be super engaged. And so I think when we talk about personalized medicine, we really need to think about what is it like to personalize information to a patient, and giving them the kind of information that they want to receive in a way that they can understand it, and then answering questions to them. So I think it depends on the patient, but having staff on board that can really spend a little bit of time to explain these things is incredibly important.
Thank you.
All right. Any final questions or comments from any of the guest speakers or any of our attendees? All right. Well, thank you everyone for hanging on. I did want to say one thing that when we designed this series, we've looked at now adding one shorter webinar on maybe about 45 minutes towards the end of this month. We're targeting March 28th at the same time at 3:30 p.m. Eastern, 12:30 Pacific, and this will be to have someone from CMMI on to discuss how they're engaging patients and sort of start to drill down on some of the things that they're doing. So we will follow up with more details on that, but we hope that that's something folks might be interested in after hearing, obviously CMMI has a lot of this in their court, so we want to start to get some education there for different organizations, and so we hope you'll be interested in that, and we'll follow up with more information.
I just want to add that we were trying to secure a CMS speaker for the sessions that we had scheduled, but because of their request process for speakers, it takes a while before we can work out a date with them when they can make a speaker available to us. And so we were not able to get a speaker to join us on any of the scheduled sessions that we had, but we're looking to be able to have one available to us. They have been agreeable. They want to schedule someone. They want to have someone speak, but the timing just didn't work out. So that's why we're going with this additional potential session, and we are excited about being able to do that.
Yep, and just one final reminder, we will send out an evaluation on this whole series and greatly, greatly appreciate if you could complete that. And so we will follow up with that and then also send the invitations out for that follow-up webinar. So with that, I'll turn over to Eleanor for final words.
Just thank you all for joining us. We were really happy to have all of you join the series, and we want to again thank Amgen for helping us with getting this off the ground and providing support to us. And thank you all, and thank our speakers, our great speakers, for their participation. And we really appreciate the time that they put into preparing for this and being available to us. We know that they added a great deal, having their actual experiences presented to you rather than just hearing a bland presentation about the facts. You actually hear someone's experiences with becoming involved in APMs and learning more through their knowledge. So I thank them very much.